Good morning, everyone. I am Dr. Sufia Athar, Specialist Obstetrics and Gynecology from Wakra Hospital, Qatar. Today, I'll present my topic, Peripartum Cardiomyopathy and Obstetrician's Ordeal. The learning objectives of my presentation will be divided into introduction about the topic, methods of my study, results, and conclusion. Peripartum cardiomyopathy is a form of systolic heart failure that affects young women towards the end of pregnancy or in months following delivery. It typically develops during the last month of pregnancy and up to 6 months after delivery in women without known cardiovascular disease. Even though it was first noticed in 1800s, its exact etiology still remains unknown. Mortality rates between 18 to 56% were reported with peripartum cardiomyopathy. The 2010 ESC working group defined PPCM as an idiopathic cardiomyopathy with the following characteristics: development of heart failure towards the end of pregnancy or within 5 months following delivery, absence of another identifiable cause of the heart failure, left ventricular systolic dysfunction with an left ventricular ejection fraction of less than 45%. The left ventricle may or may not be dilated in these cases. Some patients with LVEF between 45 and 50% may also be diagnosed with PPCM if they have typical clinical features. Due to unclear pathophysiology and variable presentation of PPCM, usually there is delay in the diagnosis and hence the management. And that is why PPCM is accountable for high maternal morbidity and mortality and needs close attention. Let's have a look at the methods of my study. I conducted this review to analyze the recent discoveries and advances in the etiopathogenesis, diagnosis, and management of PPCM. I did an online search from January 2000 to December 2021 using Medline data search. All article types including clinical trials, review articles, meta-analysis, and systematic reviews were included in this search. I found 237 relevant publications, and out of these I have taken 67 studies in this review. Let's now look at the results. So looking at the etiology and reviewing the studies till date, I found that the incidence is quite variable. It is reported as low as 0.06% to 4.84 per 10,000 live births. It's found to be lowest in Japan, where it is reported as 1 in 20,000, and highest in Zaire, Nigeria, as 1 in 100. Higher incidence is reported in African and American women, in women with advanced maternal age, women with hypertensive disorders of pregnancy, and women with multiple pregnancies. Recent studies revealed that occurrence increased from 8.5 to 11.8 for 10,000 live births from 2004 to 2011. The rising number may be due to the factors that like increased understanding and direction, increased maternal age, shifting demographics, and a high number of 12 gestations due to IVF pregnancies. Various theories supporting the pathogenesis of PPCM have been proposed till date. One of them is an oxidative stress mediated cleaved 16 kDa fragment of the nursing hormone prolactin, which is thought to damage endothelial cells and myocytes and thought to be one of the pathogenesis for PPCM. Bromocriptine, a dopamine receptor agonist, effectively blocks prolactin release from the pituitary gland, and in addition to standard heart failure therapy, this disease-specific treatment reduces morbidity and mortality in PPCM patients and supports this theory. The other theory that has been proposed is systemic and geogenic imbalance. It has been found in mice that those mice that lack cardiac PGC1 alpha, which is a regulator of pro-angiogenic factors such as VEGF, develop severe PPCM. Another theory is regarding inflammatory cytokines. Cytokines like TNF, tumor necrosis factor, and interleukin 6 are found to be elevated in PPCM, supporting the inflammatory theory for the pathogenesis of PPCM. The newer studies are supporting genetics as an important role in PPCM prevalence. Genetically mediated dilated cardiomyopathy may evolve during adult childhood and is often hard to distinguish from PPCM. Genetic mutations can be detected in approximately 30 to 50% of dilated cardiomyopathy patients. Approximately 20% of PPCM patients screened for cardiomyopathy genes have an identified pathogenic mutation, with TTN truncation most commonly implicated. Genetic testing of families is an emerging modality with some potential to augment traditional screening performed by family physicians. 15 to 20% of peripartum heart failure patients have cardiomyopathy-induced mutations in genes commonly titin, beta-myosin, myosin-binding protein C, lamin A or C, or sodium voltage-gated channel alpha subunit 5. Gene-positive phenotype negative female patients with PPCM have no clinical symptoms before pregnancy. PPCM is noted in first-degree dilated cardiomyopathy in their families. Familial mutations in the MYH7, SCN5A, and PSEN2 genes have been noted. Spontaneous mutations in peripartum cardiomyopathy patients with the MYH6 and TNNT2 DCM genes have been noted, supporting the role of genetics in PPCM. So what will be the presentation of these cases? As we know that symptoms of PPCM, which is rarely seen before 36 weeks of gestation and affects patients usually during the first month postpartum, may present as fatigue with palpitations, increased nighttime urination, shortness of breath, especially when they do any activity or when they lie flat. They may present with swelling of the ankles, swollen neck veins with low blood pressure, or it may have postural hypotension. Out of all these, a presentation of orthopnea and paroxysmal nocturnal dyspnea is suggestive of heart failure and should be taken with caution. What are the clinical signs of PPCM? So patients usually are found to have tachycardia on examination. There is elevated jugular venous pressure. Bilateral pulmonary crackles may be caused due to the presence of pulmonary edema. A third heart sound may be heard on auscultation. A dispaced apical pulse is found on palpation. Signs of cardiogenic shock may be there in severe cases. Symptoms of heart failure mimic those of normal pregnancy and often resulting in a delay in the diagnosis and preventable complications. A high index of suspicion is required for the diagnosis, as shortness of breath and ankle swelling are very common in the peripartum and even in the pregnancy. Diagnosis in these cases can be confirmed based on the diagnostic criteria laid down by the European Society of Cardiology that defines PPCM as the development of heart failure towards the end of pregnancy or in the postpartum period, absence of another identifiable cause of heart failure, left ventricular systolic dysfunction with a left ventricular ejection fraction nearly always less than 45%. The left ventricle may or may not be dilated. Echocardiography showing decreased myocardial function is essential for the diagnosis. The course of the disease ranges from mild forms with minor symptoms or severe forms with acute heart failure and cardiogenic shock. Echocardiography remains the imaging modality of choice in these cases. The use of AECG devices like Holters, external loop recorders, and implantable loop recorders were found to be beneficial in the diagnosis of arrhythmias, or if symptoms are paroxysmal that can be difficult to diagnose when the patient comes to the clinic. In evaluation of these patients, elevation of brain natriuretic peptide may be noted. In radiography, enlargement of the cardiac silhouette with evidence of pulmonary venous congestion or interstitial edema, and on occasion pleural effusion may be noted. In ECG, abnormalities may be found in 50% of the patients. A normal ECG, however, does not exclude PPCM. ECG findings in patients with PPCM are non-specific, and sinus tachycardia or really atrial fibrillation and non-specific S and T wave abnormalities may be noted. Q waves are occasionally present in the anterior precordium. PR and QRS intervals may be prolonged. Severity of the disease. If we look at the echocardiography, which is the mainstay in the treatment and diagnosis, depending on the findings, we will find the reduction in the LV systolic dysfunction and with LVEF nearly or always less than 45%. The left ventricle is frequently but not always dilated. Some people suggest doing cardiac catheterization, but not in all the cases. However, right side is recommended for those patients which are critically ill and who need more complete assessment, or if they have an ongoing evaluation of the hemodynamic state. A left-sided cardiac catheterization is recommended if there is an underlying coronary artery disease which needs to be excluded in these patients. Cardiac magnetic resonance imaging has been suggested by some, but it is generally not required to make the diagnosis of PPCM. However, it is found to be helpful in cases to assess left ventricular systolic function and left ventricular volumes, particularly if echocardiography is technically suboptimal. So what are the differential diagnoses? The differential diagnosis in cases of PPCM will be myocardial infarction, amniotic fluid embolism, myocarditis, inherited cardiomyopathies, history of treatment by anthracycline, and pulmonary embolism needs to be excluded before making the diagnosis of PPCM. The management of these cases is divided as the management which is basically supportive, that is maintenance of the airway, breathing, circulation, and use of drugs. The specific management is specified and aims at optimization of preload, hemodynamic support with inotropes and vasopressors, device therapy, antithrombotic therapy, mechanical circulatory support, and IV immunoglobulins, roles of which is still controversial. Chronic therapies include genetic testing to improve future outcome and reduce the incidence in the family. Timing and mode of delivery in this case is case specific depending on the severity of the symptoms and the presentations of the mother. Vaginal delivery is preferred over cesarean section unless indicated. Continuous CTG monitoring is advised in labor. Epidural analgesia should be offered. In patients with advanced heart failure requiring inotropic therapy or mechanical circulatory support, planned cesarean delivery with central neuraxial anesthesia is preferred. Prognosis in these cases is usually poor. The maternal mortality rate varies a lot in these patients. Studies have reported the maternal mortality as approximately 10% in 2 years, with rates ranging from 6% in 5 years and 11% in 3 years to as high as 28% in a report of 29 black patients. Cardiac transplantation rates of less than 1 to 2% per year have been reported. Variable obstetric outcomes were noted. In a study, caesarean delivery was performed in 40% of patients. Preterm birth was noted in 25%. Mean birth weight in these babies was 3.1 kg, ranging from 1.4 to 5 kgs, and 5.9% of infants were small for date. Regarding the advice on breastfeeding, women who are clinically stable should not be discouraged from breastfeeding as long as it is compatible with their heart failure medications. If decision is made to proceed with breastfeeding, avoid angiotensin II receptor blockers due to the lack of safety data of the fetus. In clinically unstable women, breastfeeding may be held till she is hemodynamically stable due to potential effects of prolactin subfragments and high metabolic demands of lactation and breastfeeding. PPCM with persistent left ventricular dysfunction are at high risk of recurrence of PPCM, and these patients should avoid future pregnancy. Sterilization procedure is the method of choice to be offered. However, depomedoxyprogesterone acetate is considered as a second-line alternative. Estrogen-containing contraceptives should be avoided in women with persistent significant LV dysfunction because of their potential to increase the risk of thromboembolism. Progesterone-containing contraceptives like pills, patch, vaginal ring may increase fluid retention, which may worsen heart failure and should be given with caution in these patients. So I finally conclude that despite several studies today, the prevalence and outcomes of PPCM are unpredictable. Usually women with early reversal of ventricular function have a better prognosis. Identifying women for high risk for PPCM is the mainstay. Multidisciplinary approach may aid in early diagnosis and management of these cases, and hence outcomes can be ameliorated. Thank you very much for your patient listening. Have a great day.